Welcome to Addressing CMV in Solid Organ Transplant Patients with CMV inSIGHT T Cell Immunity. Thank you for joining us today. I'm Denai Wells. I will be your moderator today. I'm a Product Marketing Manager at Eurofins Viracor. If you have any questions during today's presentation, please feel free to submit them through the chat. Following the presentation, we will open up with a live Q&A with our presenters to address any questions that you have. Today, we're going to review case studies featuring CMV inSIGHT T Cell Immunity, formerly known as T Cell Immunity Panel, or TCIP, which is offered from Eurofins Viracor, a clinical diagnostics company. CMV inSIGHT measures the strength of T cell responses to cytomegalovirus-specific antigens utilizing intracellular cytokine staining. A patient's whole blood sample is collected in a sodium heparin tube and is analyzed by flow cytometry, reporting the activity of CD4 and CD8 T cell responses independently. In this webinar, you will learn how these physicians utilize CMV inSIGHT in the following solid organ transplant cases: neutropenic patient, low-level CMV DNA-emia, the importance of CD4 T cell response, instances of CMV resistance, and when Belicept is used for immunosuppression. I'd like to introduce our first speaker, Dr. Justin Rosenheck. Dr. Rosenheck graduated from the University of Medicine and Dentistry in New Jersey School of Osteopathic Medicine in 2011 and went on to complete training in internal medicine at Cooper University Hospital in Camden, New Jersey. He served as the chief resident for internal medicine and then completed additional training in the specialties of pulmonary care and critical care medicine in 2018. He received board certification in both. Dr. Rosenheck also completed training in advanced pulmonary disease and lung transplantation at the Hospital of the University of Pennsylvania in 2019. His current appointment is as an assistant professor of internal medicine at Ohio State University. He is an active member of the International Society of Heart and Lung Transplantation and has special interest in the critical care management of lung transplant recipients and in transplant immunology. Welcome, Dr. Rosenheck.
Thank you for that introduction. Again, my name is Justin Rosenheck. I am an assistant professor at the Ohio State University Wexner Medical Center, and I wanted to discuss how we use CMV immunity testing in our lung transplant recipients. This is one example. DH is a 65-year-old male with end-stage lung disease secondary to non-CF bronchiectasis. He underwent a bilateral lung transplant. Of note, donor and recipient serologies were positive for CMV. He unfortunately had a complicated perioperative course. He had a difficult explant. He had primary graft dysfunction. He required prolonged mechanical ventilation and tracheostomy placement. He had renal failure and briefly was on dialysis. And he had recurrent issues with infections, notably Pseudomonas and Stenotrophomonas. He was maintained on our typical post-lung transplant immunosuppression regimen, including tacrolimus. In his case, we were dosing towards troughs of 8 to 10 for the first year, a little bit lower than our standard given his history of renal failure. Mycophenolate for a goal of 1 gram Q12 hours, and prednisone that started at higher levels but gradually tapered to a baseline of 5 milligrams per day by 6 months. Additionally, he was on antimicrobial prophylaxis with Bactrim, Monday, Wednesday, Friday, an antifungal, voriconazole, for 4 months, and valganciclovir for 12 months. Looking at valganciclovir a little bit closer, we follow guideline recommendations from the infectious diseases section of the Transplant Society, which recommend a minimum of 6 months of valsite or ganciclovir prophylaxis for recipient serology, CMV serology positive patients. Our institutional protocol for these patients includes IV ganciclovir preoperatively and on post-op day number 0, and we transition to oral valsite once patients are cleared for enteral nutrition. Of course, we dose this medication per renal function, and for recipient positive patients, we typically maintain them on 12 months of valganciclovir. DH's long-term post-op course consisted of persistent leukopenia. I'll show that shortly on a graph. Because of this persistent leukopenia, he needed a dose reduction in his mycophenolate. He also at times needed Neupogen injections for neutropenia. He suffered from one episode of mild A2 acute cellular rejection. This was at 6 months, and it was treated with a pulse dose of corticosteroids. Over time, his respiratory function stabilized with no further rejection episodes over time. And after he was able to come off of dialysis, his renal function stabilized to a new baseline creatinine of about 1.8 to 2.0. We decided to perform CMV immunity testing at 9 months post-lung transplant with the anticipation of discontinuing his valganciclovir a little bit early due to this persistent leukopenia. Here we can see his white count over time. Pre-transplant, you may note that he had a normal white blood cell count. Very quickly post-transplant, his white blood cell count started to fall, and for pretty much the entirety of the 9 months that he was on valganciclovir, he was neutropenic. At 9 months, we performed CMV immunity testing, which I'll show briefly. Based on this testing, we stopped valganciclovir, and you can see a very quick and persistent rebound in his white blood cell count. Here are the results of our CMV immunity testing. We can see both CD4 and CD8 are above reference range, indicating presence of immunity to CMV. Following demonstration of CMV immunity, Valcyte was discontinued. Again, this was 3 months earlier than our typical protocol. Following this discontinuation, we had near immediate resolution of his neutropenia and leukopenia, and we were able to resume his goal mycophenolate dosing with no further cytopenias or evidence of rejection. Over time, we continued to monitor for evidence of CMV DNA-emia post-valganciclovir discontinuation per our institutional standard. At 1 year, so this was 3 months post-Valcyte discontinuation, the patient had a mild rise in his CMV level. He went from undetectable to a peak of 219 copies per milliliter in his plasma. Given his known CMV immunity, we decided to follow these levels conservatively with no reinstitution of therapy. And indeed, his levels normalized to undetectable with no therapy and with no recurrent rises in the last 12 months of post-transplant follow-up. The summary of DH's care is that this was a highly immunosuppressed lung transplant recipient. He experienced untoward effects of our protocol antimicrobial and immunosuppression prophylaxis, necessitating down titration of his immunosuppression. He developed acute cellular rejection during a period that his immunosuppression was reduced. We performed CMV immunity testing, demonstrated CMV immunity, and this led us to deviate from our standard protocol, allowing us to discontinue valganciclovir early. Upon discontinuation of valganciclovir, we found a resolution of his neutropenia, and we were able to resume full immunosuppression dosing. Later, about 3 months following discontinuation of his valganciclovir, he had a mild CMV DNA-emia, which was observed conservatively and resolved. And that's it. Thank you so much.
Thank you, Dr. Rosenheck. Next, I'd like to introduce you to Dr. Kapil Saharia. Dr. Saharia received his medical degree from Duke University School of Medicine. He completed his residency training in internal medicine pediatrics at Yale New Haven Hospital and served as chief resident for internal medicine pediatrics in his 4th year. Following residency, Dr. Saharia completed a fellowship in infectious diseases at the University of Maryland Medical Center. Dr. Saharia then joined the immunology laboratory at the Vaccine Research Center with the NIH as a postdoctoral fellow under the mentorship of Dr. Richard Koop. He used multi-parameter flow cytometry and intracellular cytokine staining techniques to identify phenotypic and functional characteristics of Mycobacterium tuberculosis-specific CD4 T cells that could discriminate between various stages of infection. Dr. Saharia joined the Institute of Human Virology in 2012 as an assistant professor of medicine. He provides consultation services on the Transplant Infectious Disease Service and serves as the Chief Transplant Infectious Disease Section. His practice focus is on the care of pre- and post-solid organ transplant recipients with infectious concerns, patients with infected mechanical cardiac devices, including patients on ECMO, and persons infected with HIV. Dr. Saharia's research interests include infectious outcomes in solid organ transplant patients and the diagnosis and treatment of mycobacterial infections, including tuberculosis. He has been involved in NIH-sponsored and industry-sponsored clinical trials. Welcome.
Thank you for the introduction and for the opportunity to talk to you today about optimizing CMV secondary prophylaxis using the CMV-inSIGHT T Cell Immunity Panel. I have the following disclosures. I'm a consultant for Eurofins Viracor, and the opinions expressed in this presentation and on the following slides are solely those of the presenter. So today's talk is going to consist of two cases. And through these two cases, I hope to be able to get through these two objectives. The first, which is to understand how to interpret discordant CMV-specific CD4 and CD8 T cell responses, and then hopefully to be able to develop a framework for personalizing secondary CMV prophylaxis. So first case is that of a 71-year-old woman with end-stage renal disease due to autosomal dominant polycystic kidney disease who received a preemptive deceased donor renal transplant in the fall of 2021. She was admitted to our institution 4 months after her renal transplant with acute kidney injury and ultimately was found to have CMV viral syndrome. So getting to her transplantation, she received basiliximab for induction. She was a CMV mismatch, a high risk for CMV, donor positive, recipient negative. Her EBV serostatus, she was recipient positive. And she did receive a kidney from a donor that was not positive for hepatitis C. Her post-transplant course was somewhat complicated. She initially had delayed graft function and required hemodialysis until post-transplant day 6. Her creatinine did nadir at 1.5 approximately 8 weeks after her transplantation. However, by 90 days after her transplant, her creatinine had increased to about 2.5. She was maintained on routine antimicrobial prophylaxis with Bactrim, as well as valganciclovir for 3 months, as she did not receive lymphocyte depletion for her induction. Her maintenance immunosuppression consisted of tacrolimus, mycophenolate, and prednisone. So in terms of her post-transplant course, she was noted to have neutropenia approximately 90 days after her kidney transplant, and at this time her Bactrim was held and her mycophenolate dose was reduced. She also received a single dose of GCSF. She was found to have Enterobacter cloacae urinary tract infection, which was treated with a 7-day course of meropenem. And then a renal biopsy, because of her rise in creatinine at around 90 days, was negative for acute rejection, but did demonstrate some moderate arterial sclerosis and mild interstitial fibrosis with tubular atrophy. Following this renal biopsy, unfortunately, her creatinine continued to rise up to 4.5, which is what prompted her admission to our medical center. And upon admission, she had a renal ultrasound that showed some renal artery stenosis, for which she underwent balloon angioplasty. A renal biopsy was performed again, this time showing focal neutrophilic cast concerning for acute pyelonephritis, and a blood and urine culture, which supported this diagnosis of acute pyelonephritis, as they were both positive for Klebsiella pneumonia as well as Enterobacter cloacae complex. And this was managed once again with meropenem. Now, additionally, she was found to have a detectable CMV viral load with approximately 6,200 copies of CMV detected in her blood. And note that this is occurring several weeks after her valganciclovir prophylaxis had ended. So in terms of her CMV course, she was started on IV ganciclovir promptly after the detection of CMV. However, 2 weeks into her course of ganciclovir, her CMV viral load climbed to 86,000 copies. This prompted us to switch her antiviral therapy to foscarnet, a CMV genotype which was sent to look for possible UL97 mutations, did come back positive with a UL97 mutation detected. And on foscarnet, we noted that her creatinine did slowly start to improve, as did her CMV viral load, which had decreased to 4,300 copies by day 21. Now, around this time, unfortunately, she did start to develop an increase again in her creatinine, as well as started to develop neutropenia. And so her foscarnet was switched to maribavir. And over the course of the first week of maribavir therapy, her CMV PCR continued to improve. And a CMV-INSIGHT T cell immunity assay was sent at this point to try to help determine whether or not she might benefit from secondary prophylaxis, or if she could simply be taken off of maribavir once her viral load had cleared. Over the next couple of weeks, she continued to respond. Her CMV PCR was not detected at day 35, nor was it detected by day 56. However, in the interval, she did have another renal biopsy because of a persistent elevation in her creatinine showing acute rejection this time. And so she was administered IVIG as well as increase in her maintenance immunosuppression. Her maribavir, unfortunately, could not be discontinued as a result of the increase in her immunosuppression. And so she was maintained on this for several additional weeks. Through day 72 of her CMV treatment course, she maintained an undetectable CMV PCR, and a repeat CMV-INSIGHT T cell immunity assay was sent at this time. Shown on this slide are the results of her 2 CMV T cell immunity assays. The first, which was obtained on day 28, which shows a positive response to the CMV CD8 specific T cells, but her CMV specific CD4 T cell response was quite low. As a result of this, as I mentioned, she was continued on her maribavir, but also because of the augmentation or immunosuppression. As we get to day 72, what you see here is that her CD8 T cell response continues to increase, and she now actually has a positive CMV-specific CD4 T cell response on this CMV-INSIGHT T cell immunity assay. Her CMV PCR was not detected several days after this assay was resulted. She did develop a progressive rash. And while this rash may not have been related to maribavir, she was actually on multiple other medications that could have contributed to the rash. We did elect to stop her maribavir at this juncture, given that she demonstrated good CMV-specific T cell immunity, both by the CD4 and the CD8 specific T cell responses. The table here shows her subsequent CMV PCR results following the discontinuation of maribavir for secondary prophylaxis. And over the first several weeks, you can see her CMV PCR results remained undetectable. She then developed a very low level of viremia by day 119, of 814 copies. But despite this, we elected not to restart her antiviral therapy, as our CMV T cell immunity panel showed that she actually had good T cell immunity. And this is borne out over the course of the next several weeks when she continued to maintain a very low level viral load without any signs or symptoms suggestive of CMV, recurrent CMV infection. Now, unfortunately, this patient had multiple other comorbidities and remained hospitalized for several months. She eventually developed a septic shock and was transitioned to comfort care. This outcome obviously was rather unexpected, but as it relates to her CMV infection, I think one thing that we can see here is that with the CMV T cell immunity that had developed, she did not have any recurrent CMV events. I would like to juxtapose that first case with case number 2, which is a case of a 67-year-old woman with a history of interstitial lung disease and scleroderma who received a bilateral lung transplantation in 2018, whose post-transplant course has been complicated by recurrent CMV viremia. Our patient received recombinant ATG for her induction. She had an intermediate risk for CMV, as the donor and recipient were both CMV seropositive. Our recipient was also EBV seropositive. Our recipient in this case received valganciclovir for up to 2 years post-transplantation. She was maintained on Bactrim for her pneumocystis prophylaxis. Her main immunosuppression consisted of tacrolimus, mycophenolate, and prednisone. With respect to her CMV history, she stopped her valganciclovir prophylaxis approximately 2 years after transplantation in the spring of 2021. And within several months of stopping her prophylaxis, she was admitted with CMV viremia and CMV colitis. Now, this resolved with IV ganciclovir. She was put on secondary prophylaxis, which was then stopped in the fall of 2021. Shown here are the results of her CMV PCR assays, which demonstrate a good response for antiviral therapy. And then these results from day 35 onwards show an undetectable viral load while she's maintained on secondary prophylaxis. Now on day 119, we did obtain a CMV T cell immunity assay to determine whether it would be reasonable to stop her secondary prophylaxis. Shown here is the results of that assay, which show a CD8 specific T cell response, but a very weak CD4 CMV specific T cell response. Now, despite the low CMV specific CD4 T cell response, we elected to stop her valganciclovir prophylaxis and monitor very closely with CMV PCR every 1 to 2 weeks. Unfortunately, 6 weeks after stopping her prophylaxis, she was admitted to our institution again with CMV esophagitis. And at this time, her CMV PCR results were over 1 million copies. She had an EGD, which confirmed the presence of esophagitis. She again was treated with IV ganciclovir for at least 14 days, after which she was transitioned to oral valganciclovir, given improvement in her symptoms, and then eventually transitioned to secondary prophylaxis, which started approximately 6 weeks after her initial diagnosis. And again, on this table, you can see the CMV PCR results in response to therapy. By day 49, she has an undetectable CMV PCR for several weeks and is at this point transitioned to her secondary prophylaxis. And she maintains an undetectable viral load over the course of the next couple months. So our CMV T cell immunity panel obtained on day 119 once again showed that our patient had a low CD4 CMV specific response and a very positive CD8 CMV specific response. Again, we were faced with the question about whether or not to continue her secondary prophylaxis in light of these results. And we elected once again to stop her prophylaxis and move forward with preemptive monitoring, checking CMV PCRs every 1 to 2 weeks. Unfortunately, after stopping her prophylaxis, the patient had a third episode of CMV viral syndrome. And this again occurred within a month of her stopping her prophylaxis. She once again responded to valganciclovir treatment, and she is now on lifelong CMV prophylaxis. In this case, it appears that our patient's recurrent CMV infections were occurring in the setting of poor CMV-specific CD4 T cell responses, suggesting that patients who have poor CMV-specific responses will remain at intermediate to elevated risks of future CMV events. So to conclude, from these two cases, and from what has been published in the literature, it appears that CMV-specific CD8 T cell responses may not be sufficient alone for protection against CMV, and that patients that do not have CMV-specific CD4 T cell immunity, as detected by the CMV T cell immunity panel, remain at higher risk for future CMV events. So why is this? Well, part of this, I think, can be explained by the fact that CMV-specific CD4 T cells are needed to provide CD8 T cell help. In addition, there is some data suggesting that CMV-specific CD4 T cells also have direct antiviral activity. So with this, I will conclude and hope that through these two cases have shown how we can use the CMV T cell immunity panel to help guide secondary prophylaxis, and have also shown the importance of the CMV-specific CD4 T cell response in guiding our prophylaxis decisions. Thank you for your time.
Thank you for outlining the importance of CD4 T cell response, Dr. Saharia. Now I'd like to introduce our final speaker, Dr. Abhay Dhand. Dr. Dhand is the Director for Transplant Infectious Diseases and Antimicrobial Stewardship at Westchester Medical Center in New York. He completed his training in infectious diseases at Tufts Medical Center in Boston. Dr. Dhand is also an Associate Professor in Clinical Medicine at New York Medical College. This year, He was recognized by Infectious Disease Society of America as a distinguished physician with the FIDSA designation. His research interests include the development of personalized interventions to prevent and treat infections in immunocompromised patients, prevention of recurrent infections in at-risk patient populations, and outcomes associated with extended criteria donation in solid organ transplantation. Welcome, Dr. Dhand.
Hello, everyone. My name is Abhay Dhand. I'm one of the transplant infectious disease physicians in New York, and it is a pleasure here to be today as to present my cases in the CMV inSIGHT case study series. I'm going to start with case number 1. Before that, my disclosures. I'm a consultant and I have received research grant from La Jolla and Paratech Pharmaceuticals. I've also received research grant from Regeneron, which are out of the scope of the presentation today. Current series is being sponsored by Eurofins ViraCore, and the cases that I'm going to present, these are representation of true cases, but some of the demographic details have been altered. Case number 1. It's a 50-year-old male with non-ischemic dilated cardiomyopathy, hypertension, diabetes, obesity, chronic kidney disease, peripheral arterial disease. He underwent an heart transplant in 2017. His CMV serostatus was donor positive, recipient negative. He received thymoglobulin induction, which was followed by standard maintenance immune suppressive therapy with prednisone, Myfortic, and tacrolimus. He also received standard valganciclovir and trimethoprim sulfamethoxazole prophylaxis. His immediate post-op course was a little bit of rocky course with a lot of GI intolerance, which was associated with some missing medications. He also gained a lot of weight along with fluctuating kidney functions. Now I'm going to go talk about his the status of his CMV infection. So in this slide, you would see days post-transplant, and you will see the CMV values, the treatment course, and along with the supporting values. So I'm going to start with day 1 when he received the standard full dose valganciclovir prophylaxis. And around 2 months into his transplant, he was getting CMV PCRs checked. Part of it was because of the GI side effects that he was having. Around 2 months into the transplant, he develops a PCR, which was below the threshold, but it was still detectable. So the standard prophylaxis was continued. And as you see down here, you see the fluctuating creatinines that he was having at the same time. Further down into the 3rd month of his transplants, he develops CMV viremia. And in the bottom, you see the log values. So there's a significant increase in the CMV PCR along with the log values. And since he was considered possibly he wasn't tolerating the valganciclovir, he was admitted and was started on ganciclovir. Along with that, he received 1 dose of cytogam. 1 week into the therapy, as expected, we saw the viral load to increase along with increase in the log values that led to stopping of the mycophenolate with some improvement in the absolute neutrophil counts. 2 weeks into the therapy, the viral load, as expected, started to come down, even though it started to come down very, very slowly. That led to sending off the resistance pattern. And further, around 10 days after the test was sent, we had a decrease in the viral load, decrease in the log values. But as expected, there was ganciclovir resistance that was noted for CMV, with a mutation that might be dealt with by giving high dose ganciclovir. So that is why ganciclovir was switched. Now you see ganciclovir switched to 10 milligram per kilo along with creatinine that was improving. So at this point, our patient was on very high doses of ganciclovir. We decided to continue this antiviral therapy because there was an improvement in the viral load, even though it was not to our satisfaction. He further, there is improvement in viremia. He gets discharged home on IV ganciclovir, again with some fluctuation in the kidney function and decrease in the absolute neutrophil count. Follow-up CMV PCRs become lower and lower. At this point, his ANC becomes lower, and once he gets discharged, his kidney function starts to go up. He's requiring multiple doses of Neupogen, that is GCSF. And further, many months into the therapy, we finally get one CMV viral that is below the threshold level. The follow-up viral was again below the threshold, but was detected. And again, follow-up PCRs were very low level of viremia. Now we were in a situation in which we had low level of viremia in a patient who was having a lot of issues with leukopenia and neutropenia, fluctuating kidney function, and we were dealing with primary resistant CMV. So this leads to the therapeutic dilemmas. Should we stop the treatment? Should we switch treatment? All this time we made a decision not to switch to foscarnet because of his weight gain, because of his risk of going into renal failure, and his tolerance to ganciclovir and decrease in the viral load. So we decided not to switch the therapy. Would he be a candidate for secondary prophylaxis? If he were a candidate for secondary prophylaxis, what would be the medication that we would use for secondary prophylaxis, and how long should we give the secondary prophylaxis for? Now, again, this is a very unique case, and it was one of the first cases in which we actually utilized CMV immune assay and utilized a newer antiviral therapy that just got approved that month to help guide these things. So these were the subsequent steps. This was our first patient in which we sent a CMV immunity assay. And as you see here is representation of the test in which you have the percentage CD4 cells. And the result, the standard result would be, as expected, would be higher than 0.2 that would be expected with a lower risk of recurrent CMV infection. So here the immune response, the CD4 immune response was below expected, CD8 immune response was higher than expected, and the baseline, the standard tests were considered to be optimal. So based on this immune assay, we decided that this person, our patient, was a candidate for secondary prophylaxis because the risk of recurrent CMV after stopping the therapy could be higher. And in this scenario, we would have to either go back to high-dose ganciclovir or to give foscarnet. And as a team, we decided not to take that risk. So this started at the same time when letermovir became available. So we decided to switch the patient to letermovir 480 milligram once a day. The patient remained on secondary prophylaxis with letermovir for 3 months, and the subsequent PCRs remained negative. Now, this was not the end of the case. 1 year later, he developed lower extremity edema, had a lot of weight gain, was a little bit non-compliant with his medications. He had a heart biopsy which showed rejection, which was treated with pulse steroids. Now that brought back the dilemma again as we were going up on the immune suppression in a patient who had resistant CMV before. Should he be a candidate for CMV prophylaxis? So we sent a follow-up CMV immunity assay, and the results, the partial results, showed that this person had more than expected both CD4 and CD8 response to CMV. And as a basis of this result, we decided no further CMV prophylaxis was required, and this person continued to stay off CMV prophylaxis and did not develop CMV infection. So you see within one case, there are two extreme scenarios in which, based on the clinical judgment, based on the clinical scenario, the patient response, we were able to utilize a new diagnostic test to help add to lot of the evidence that was available, lot of subjective evidence. We were able to add some objective evidence and help guide our clinical therapy and decision making. We move on to case 2. Case number 2 is a 60-year-old male with diabetes, hypertension, who developed end-stage renal disease and was on hemodialysis, was listed for kidney transplant, and in 2021 undergoes disease donor renal transplant. He gets thymoglobulin induction with maintenance immune suppression with tacrolimus, myfortic, and prednisone. His CMV serostatus was donor negative, recipient positive. Immediate post-transplant, he develops delayed graft function followed by chronic kidney disease. Based on that, our institutional protocol, the immune suppression was switched from a CNI-based immune suppression to a CNI-sparing regimen with introduction of belatacept. Tacrolimus is slowly tapered off. He remains on myfotic at a lower dose and a low-dose prednisone. As our institutional protocol, he finishes 6 months of valganciclovir. So in this slide, what you see is, again, the clinical course of what is unique to this particular patient. And this patient happens to be the most recent patient in which we utilize CMV immunity assay to help guide, make our treatment decisions as well as diagnostic decisions. So I'm presenting two extreme cases. One of our first cases, which was in which we were looking at monitoring of resistant virus, and this second case in which we were looking at a newer immune suppressive therapy, belatacept, which in recent literature has been associated with increased risk of CMV, increased risk of CMV disease, as well as delayed onset of CMV infection, especially in kidney transplant patients. So here what you see is the time course. That is on top, you see months post-transplant, and you see the CMV results, and you will see what was the treatment that given and what was the results of the CMV immunity assay. So around 2 weeks after stopping the therapy, he develops low level of viremia, no symptoms. We decided not to treat this level of viremia, but we did send a CMV immunity assay, which basically shows a suboptimal CD4 and a CD8 response to CMV antigens. A repeat PCR in 2 weeks showed increase in the CMV viremia along with the logarithmic increase in the CMV viremia. And this patient, at this time, patient developed low level of symptoms that included fever and some GI symptoms. So he was started on valganciclovir for 3 weeks with resolution of viremia. Along with treatment of valganciclovir, MMF was further lowered. CMV PCRs became non-detectable. Sequential PCRs became non-detectable at around 3 weeks. Treatment was stopped, and we did not give any secondary prophylaxis at the time. Again, after stopping the first event of CMV, after stopping the primary prophylaxis, around few weeks later, around 4 to 5 weeks later, he presents again with symptomatic illness with significant amount of viremia along with low level of symptoms. So again, he undergoes valganciclovir. At this point, belatacept was stopped, tacrolimus was restarted, and the levels were monitored closely. Mycophenolate was stopped. Within 3 weeks, 3.5 weeks of therapy, his sequential CMV PCR viral loads became non-detected. The treatment was stopped. At this point, we sent a CMV immunity assay to decide if the patient might be a candidate for secondary prophylaxis. So 3.5 weeks into the therapy, when we were ready to stop the treatment, we sent a CMV immunity assay, which showed that there was an improvement in the CD4 response, but there was a slight lower trend in the CD8 response. So based on this, again, slight suggestion that this person, based on the clinical presentation, based on the immune suppression, and further based on the CMV immunity assay, might be at a higher risk of developing recurrent CMV infection after stopping the treatment. So we made a decision to start this person on secondary prophylaxis, which was with valganciclovir, and we repeated the CMV immunity assay in 1 month. And what you see in the repeat CMV assay is an improvement in the CD4 response and the CD8 response, which is above the cutoff, expected cutoff, which would be associated with a lower risk of reoccurrence. So based on the clinical presentation, based on our ability to further lower the immune suppression, stopping the belatacept, and being ability to monitor the tacrolimus levels, decision was made to stop the prophylaxis. Around 3 months after stopping the secondary prophylaxis, we did detect a very low level viremia of 146. Our institutional assay cutoff is 137. Person had no symptoms. So based on the previous immunity assay that we had a few months ago, low level of viremia, no symptoms, overall ability to cut down on the immune suppression, decision was made not to treat the CMV viremia, and subsequent CMV viral loads remained negative. So what you see here are basically two cases, which are diverse two cases, one in a heart transplant in which we were able to decide on stopping the therapy and giving secondary prophylaxis for a resistant virus. And in second case, what we have is a case of person who's overall severely immunocompromised without overall with the newer immune suppressive therapy, for which we are unable to kind of quantify what the level of immune suppression that the patient might have. And this new therapy is also known to be associated with increased risk of CMV infection and delayed CMV infection. So here we have, again, a very, very objective test, which along with a lot of other evidence helped us make a treatment decision to optimally treat the patient and avoid all the morbidity and the mortality that might be associated with CMV infection or CMV disease. At this point, I'm going to stop, and we'll stop for some discussion later. Thank you.
Very informative, Dr. Dhand. Thank you for sharing. This concludes the main portion of today's presentation. Thank you to all of our speakers for their intriguing case studies and time today, and thank you to our viewers for joining us. It is now time to begin the Q&A portion of today's webinar. As a reminder, please submit any questions you have through the chat, and we will work through as many questions as possible before the hour is up. If we are unable to get to your question, we will follow up after the presentation today to respond. But let's get started.
Hello there. I would like to ask our presenters to go ahead and come on to screen and go ahead and unmute yourself so we can begin the live Q&A portion today. Attendees, please, if you have any questions for presenters, please go ahead and submit them. We will try to work through as many questions as we have time for. Unfortunately, Dr. Rosenheck will be unavailable for the live Q&A portion. So if you do have any questions for him in particular, please still submit them and include his name so we can direct any questions to him and follow up with you after the fact. All right. Dr. Dhand, Dr. Saharia, can you hear me? And come on, go ahead and share your screen.
I can hear you. Are you able to hear me?
Uh-oh, maybe I'm having audio issues. I apologize. Can you guys hear me?
I can hear you.
Okay, can you hear me still?
Yep.
Okay, perfect. I apologize. Okay, fantastic. I couldn't hear you guys. I will take out my headphones. Sorry for those technical difficulties. All right, let's go ahead and get started with some questions here. So first off, I would like to ask both of you, maybe we can start with Saharia. Can you please tell us a little bit about when and how your team decides to utilize CMV-inSIGHT T cell immunity testing? Is it protocolized, or what situations typically prompt ordering of the test?
Yeah, so we are certainly working towards using the CMV T cell inSIGHT assay in a more standard protocolized manner. We haven't gotten there yet, but I would say that the most common situation in which we send the CMV T cell inSIGHT assay is usually guiding secondary prophylaxis decisions. And then in some of our high-risk patients that have gotten lymphodepletion, if there's a issue with ongoing lymphopenia and there's concern about potentially needing to extend prophylaxis, this may come up many times in our lung transplant recipients. So that might be a situation where we might use a CMV T cell inSIGHT assay to guide primary prophylaxis as well.
Dr. Dhand?
Yeah, so I think we are also in the process of learning more about how to use the assay And at this point, we've used it almost for 3-4 years in different clinical scenarios. And when we started, we kind of used it more for challenging scenarios to try and individualize the care. And I think what we try and do is learn all the changes that are happening in the recipient selection, in the donor selection, changing the immune suppression, and the therapies that are available to try and optimize the best possible prophylaxis for that particular patient. So the common scenarios, again, as Dr. Saharia mentioned, intolerance to prophylaxis. Leukopenia is a huge concern, especially in our liver transplant patient population who come in very sick because of the type of patients who are undergoing liver transplant has changed in the last 2-3 years quite a bit, at least for in our transplant setting. So leukopenia is a huge issue, and we do have an institutional protocol which is kind of similar to other institutions. We try and stop the Bactrim, switch to other PJP prophylaxis, cut down on myphotic if we can. And then the question becomes for CMV assay. So we have utilized this assay in patients who are not responding to, who have severe leukopenia, neutropenia, despite all the options, and are requiring frequent Neupogen or intolerant to Neupogen to try and decide what might be the right therapy for primary prophylaxis. Again, recurrent CMV is kind of the cases that we mentioned, especially in the settings where it is not easy to optimize or lower the immune suppressive therapy. This could be in the setting of a person who has developed rejection, where you're actually going up on the immune suppressive therapy, or other conditions that might be their person is highly sensitized and you really do not want to cut down on the immune suppression that much. So I think that's another scenario. For recurrent CMV, as I mentioned, people who develop 2 or 3 episodes of CMV, to try and prognosticate, is there another test that might help decide when to stop the therapy. So in this scenario, what we have started to do is more sequential CMV immunity assays. Now that sequence depends on how quickly the patient comes in. Now that is also one of the things that you have learned when to do the test. People have to come in early in the morning, so the test is sent at a certain time, it is received at a certain time, so the test becomes available. Otherwise you miss the cutoff, then the patients come back after 3-4 weeks. So that part is still, we are still learning from the methodology of getting the test. And the third thing where we use the test, which is a very rare scenario, would be for resistant CMV. That was the first case that we presented, because that is where you end up using a lot of nephrotoxic or other toxic medications. Luckily, we have 2 new antiviral therapies that are available that has made our life much easy. But we did have in 2017, 2018, a series of patients who basically came in with the exact same scenario. And I think that is where we found all the newer antivirals and the new diagnostic therapy to be very helpful to try and individualize the care for that particular patient. So I think going forward, as we learn from our experience, as we learn from other people's experience, as we learn from overall more knowledge that is available about CMV-specific immunity, utilizing the commercial tests that are available, I think that would be to try and integrate into our clinical pathways for all the patients.
Absolutely. Thank you both for your responses. We have another question. Is the assay available in-house, or is it a send-out? It is a send-out test. The test is performed by Eurofins Viracor, and as Dr. Dan noted, it is a live cell test. So it does have pretty important and stringent shipping requirements and draw times to ensure that the cells remain viable as part of the testing, and that is one of the results that you do get, is a cell viability test to ensure that the cells that we've received are still alive. Draw times are usually early in the morning, so they can be shipped as quickly as possible to be received by our laboratory. Okay. We have another question that comes in. What are the factors affecting the CMV inSIGHT assay? Either of you care to take that question?
Sure. Well, so one of the things that I've certainly noticed as we've sent this test out, again, it is measuring CD4, CD8 specific responses. So one of the parameters that I think you have to be really careful about when you're sending the assay is taking note of the lymphocyte count of the patients. And so if you have a patient that has pretty severe lymphopenia, maybe because they got T cell depletion, and they're profoundly lymphopenic, well, the test may not perform as well in those situations, and you may end up with a indeterminate test result. And so we've certainly had situations where that has come up. I think other reasons for indeterminate testing, obviously, may depend on what happens in terms of some of the background responses. And so if, when the assay is run, there is a high response, in your negative control sample, that may result in an indeterminate result for the assay. Now, why you have high background, that might be something, I may not be able to easily answer that, but maybe Denai can. But I think, certainly taking into account the degree of immunosuppression and the severity of lymphopenia, I think would be certainly important considerations.
Absolutely. I would love to answer on high background. However, that is not my area of expertise, but that is a really great question, and I will follow up with our scientific expertise to answer that for you guys, and we can follow up post presentation. But Dr. Dan, is there anything you'd like to add to that answer?
I would echo the same thing. I mean, it's basically an interferon gamma release assay. So, all the things, mainly overall immune suppression and severe malnutrition and etc. that are associated with poor interferon gamma release to any antigen, same thing specifically used for TB or CMV would expect. And I think the other thing is just to make sure the test is drawn appropriately, so we do follow the right tube, because that is sometimes it gets discarded, sits around. I think you have to work with your lab because it's not really integrated in our order system. So in our institution, it gets sent out as a miscellaneous test. So I think we just want to make sure it is communicated appropriately between the staff who's drawing and the receiving lab to make sure it is processed in time. So I think lately what we have done is our return for samples that have been rejected or the test is not appropriate is improved significantly with our workflow. So I think that has been quite an important improvement that we've been able to make in the last 2 years or so. And one more thing I may add, I think it's just for the test performance. I think what we all have to learn from that is how actually to utilize that test. So maybe you have to utilize it for all the patients. So I think if you were to use it in selected patients for selected scenarios, and again, I think hopefully this seminar will help prompt that discussion to kind of do what is the risk benefit of sending that, or risk benefit cost of sending this test versus risk benefit cost of continuing the prophylaxis or secondary prophylaxis or developing subsequent CMV disease or CMV infection. So, there are various studies that do that kind of support going in either direction. So I think part of it in our learning process has been to learn about the test characteristics to maximize this cost benefit versus the risk ratio from either of the scenarios.
Yeah, absolutely. You bring up some great points. Most of these antiviral medications are extremely expensive. And not only that, they have really negative side effects for those patients. So if they, have CMV immunity, they can be taken off a little bit earlier, that can allow them to save on some of those other costs, so to speak. But thank you guys for that, that answer. And you guys have spoken a little bit on this particular question, but maybe we can more specifically answer. Do you find value in monitoring CMV T cell immunity more than once, rather than just at a single time point, and why?
Sure. Do you want me to start?
Yeah, sure. Let's continue with that workflow.
So I think it's a great question, and I think some of the cases that were presented during the seminar, I think highlight potential reasons why you may want to repeat the CMV T cell assay. I think that you have scenarios where you might send it either to guide decision making regarding primary prophylaxis or even secondary prophylaxis, where the assay shows that the CD8 or CD4 or both responses are low. And in those situations, these are individuals who may remain at risk for future CMV events. And so the question then becomes, whether these individuals over time may actually develop a stronger CD4, CD8 CMV-specific response or not. I mean, I think where I struggle is trying to square away, when to resend a repeat assay. Do you wait a month? Do you wait 2 months? Do you wait 3 months? Do you wait 6 months, a year, right? I mean, I think, that obviously has not been worked out. And then what do you do in the interim? Do you keep patients on prophylaxis? Do you move over towards preemptive monitoring? And I think the second case that I had discussed was that exact scenario, the challenges that are presented when you have patients that have low CMV-specific responses. Because as was already alluded to, there are downsides to maintaining patients on prophylaxis. So I think the situation where you have someone with a low CMV-specific response, if it is occurring in the setting of augmented immunosuppression, well, certainly you might be able to wait until the immunosuppression is decreased, and then maybe repeat it again as you try to make decisions about prophylaxis. Because I think the decrease in immunosuppression can then potentially lead to improved CMV-specific responses. So the exact timing I don't think is at all worked out. But I think it really depends on the case-by-case scenario in terms of when you really would need to repeat the CMV T cell assay.
Absolutely. And Dr. Dhand, anything to add to that?
Yeah, I would completely agree. I mean, I think we're all learning in this thing, and I think what we do is try and, again, know what the scenario we are sending the CMV, like what is the knowledge that we're going to get from there, and what is the intervention we're trying to make. So it's decided, individualized on each patient, depending on what challenge. If they're tolerating CMV therapy, they have no problems, then, that's fine. But if somebody's becoming intolerant or the risks of any therapy would be there, then we might repeat it sooner. So, or the other scenario that I presented, I think, was when we go up on the immune suppression, not necessarily T cell depleting therapy, but you go up cumulative on the immune suppression from other scenario. Do you really need to start secondary prophylaxis or not? I think that is another way to kind of establish a baseline. And if there is low level viremia that we detect down the line, it helps us. Again, does the patient require treatment, or can we just do preemptive monitoring? So I think there are a lot of options that are there that we mix and match. And honestly, that is one of the reasons we have not been able to theoretically properly protocolize it, because we've been just using it for selected cases in the right scenario, knowing what exactly we are looking for. So as long as we have an idea of what answer we're looking for, I think then we basically send the test to try and help get the answer and make any of the interventions.
Yeah, that makes a lot of sense. Okay. We had a couple cases that were directly post-transplant within, that first 200 days. We also had a couple cases or scenarios where we saw, a year to 2 years post-transplant. Can you talk a little bit about the value of treating people who are using the test to look and treat patients that are 1 year, 2 years post-transplant?
So is a question whether you would use this assay to determine if a patient warrants treatment. Is that what they're getting?
Yes, sorry, yes.
Yeah. I think that's certainly an interesting question, especially, in patients who are further out. Certainly I think it depends on the scenario in which, the CMV syndrome is occurring, how symptomatic they are, what is the degree of viremia, what's happened to immunosuppression. You could certainly envision a scenario where someone has low-level viremia in the setting of some other illness, and it may have nothing to do with immunosuppression. In which case, you can certainly, if there is a good CMV-specific T cell response, you could opt to just watch them. But I think that there are lots of variables at play in these decisions. The degree of viremia, whether or not there are symptoms, and again, just changes to immunosuppression, all those I think would factor in to the decision-making process. And so I'm not sure that I would rely simply on just the CMV T cell assay to make a decision on treatment.
Absolutely.
So yeah, I think that is a completely valid point. But one thing I would add to this conversation is it is a subjective test. So I think when you're looking at some objective markers, I think having subjective test at least a little reassuring. And we find it particularly helpful. So we are again in a unique scenario in which we have patients who come from 4-6 hours away for post-transplant care. And especially in the winter times when you have a snowstorm, to come to get the lab work done routinely, or to get a CMV assay drawn at an outside lab, which can take a little longer to come back. So that follow-up sometimes is not that optimal. So say you have a person with low-level viremia, if this person can come back in 2 weeks, and they're asymptomatic, it's very easy to monitor. For some people who we cannot rely on having a routine follow-up or having follow-up viremia done, sometimes we find useful in that scenario just to develop a baseline. But this is for late CMV infection. You already have a low-level viremia and you just want to decide down the line if the viremia goes up or develop symptoms or whatever. Do you want to, I think if they develop symptoms, it's an easy call, you have to treat it. But if the viremia persists, sometimes what we do is lower the immune suppression, and then is there any role of doing it again down the line? So I think it's been helpful if you have low-level viremia, you cut down on the myphotic or you stop the myphotic. Do you want to repeat it again in 3 months just to see where we are in future if we have to go up on the immune suppression? I think it helps guide some of those clinical scenarios. So again, I think each institution kind of has different challenges that they deal with, different kind of patients that they deal with. But consistently, I tell you, I think our biggest challenge for late transplant patients has been with neutropenia and leukopenia. And our incidence of leukopenia, we do not have lung transplant in our institution, but our biggest challenge has been with liver transplant patients and with heart transplant patients. Incidence of leukopenia, even late post-transplant, even in people we've been able to lower or stop the mycophenolate even after they've come off the Bactrim prophylaxis after 1 year. I think that becomes a concern. So I think that is where in a super selected number of patients, we find it useful.
Yeah, absolutely. No, it's just interesting. Wanted to kind of hear your guys' thoughts on that particular utilization. So I think we are at time. So once again, I want to thank you both for your time and for your fantastic case study presentations. Viewers, I hope you came away with some little nuggets from today's presentation. Please feel free to reach out if anybody has any other questions that they would like answered. We can follow up offline. But thank you. I hope everyone has a great day and a great rest of the week.
Thank you, everyone.
Thank you very much.
Bye-bye.